So we're going to give just an overview of what's going on in telehealth here in the state of Indiana, and then, as Ali said, we'll use the chat function at the end and pepper me with questions. I'll answer what I can, and I'll be honest and let you know if I need to research something more. So trying to put these slide deck together, I always like to talk about the healthcare costs in the United States. We are one of the most expensive countries in the world as far as our healthcare costs, and a lot of the stuff around telehealth and accountable care organizations and the move from fee-for-service to value-based purchasing using telehealth really helps to be more efficient in a medical practice. So here's some information here. The one that really caught my eye, I have 2 young girls. We go through a lot of eggs and a lot of milk in our house, and I just bought 18 eggs yesterday for 88 cents on sale at the local grocery store. If I had to spend $55 on eggs, that would severely hinder my grocery bill each month. So we see on this chart that hospital care is the majority of the costs in U.S. healthcare, physicians, prescription drugs at 10%, and we all are familiar with the opioid crisis that's going on today. And here, as we compare to other first world countries, you can see the drastic difference between the United States and France, which is the next country as far as percentage of healthcare funding as part of the gross domestic product. So I'm going to tell you about that video. We're not going to try and show it again. Ali has access to the slides, and she can certainly send those slides out that has the link. But that video that I like to show talks about how we have a broken healthcare system because we reward healthcare providers by paying them more when they do more expensive procedures, and how we often in our healthcare culture, we don't really try and get to the root cause of a person's problems, or we just give it a pill. You know, oh, you've got anxiety. Okay, we'll take a pill. But why are you anxious? You know, why? What's going on in your life? We don't spend that time with primary care to really learn what the problem is. Oh, Ali's got my slides. Awesome. And then how now we're transforming care. We're looking much more at the social and economic determinants of health and the person as a whole, and more on the wellness side. So here we see all of these words popping up on the screen, different things that are buzzwords that we hear in the industry, and all of these things we can use telehealth to help us to provide better services more efficiently. So on this next screen here, you see a little bit more about payment reform, and I'm not going to spend a lot of time on this, but as you look through that, there's been the medical home or the primary care medical home. Those terms have been around for a long time. And when we start, it's interesting because legislation takes a long time to catch up to what's the reality of going on in how people are providing care. But you see in 2015 on this slide that Medicare first introduced payment reimbursement for chronic care management with that code 99490 at $40 a month. Go ahead and go on to the next slide. So since 2015, we're starting to see a big change in the way healthcare is being provided and reimbursed, even more importantly. There's an organization called the Institute for Healthcare Improvement, and they developed the concept of the triple aim, wanting to provide healthcare to the entire population, a better experience of care at a lower rate. Now, it's really easy to do 2 of those 3 things, but trying to do all 3 of them at the same time is very difficult. And also, there's been some talk, as well as the triple aim is the quadruple aim, where you add in the provider satisfaction on that. the younger providers that are coming out of medical school today don't want to work those 60, 80-hour weeks. They don't want to work nights and weekends. They want to have a better life-work balance. And so the money isn't quite as a motivating factor for them as it was in providers that are more towards their baby boomer age. Go ahead, next slide. So here I was talking about social determinants of health, and on this screen here we see from countyhealthrankings.org, it's really interesting to note that the clinical care, I mean, today we're talking about the clinical care and the reimbursement for telehealth as part of that clinical care. You note in the middle of the page that clinical care is only 20% of the total of population health. And we see so many things. Social and economic factors, 40% of a person's well-being. Their physical environment, 10%. Their health behaviors, 30%. Clinical care can't touch that. There's so many things that make up an individual's health that can't really be diagnosed or seen from that 15 minutes that you spend with a doctor in a typical doctor's visit. So here, my title, Program Director of the Upper Midwest Telehealth Resource Center. You see the national map. We have 12 regional telehealth resource centers and 2 national centers. All 14 of us work very collaboratively together, and we're all grant funded through HRSA. So under Health and Human Services, under HHS, and then HRSA, Health Services Resources Administration, and then the Federal Office of Rural Health Policy, and then the Office of Advancement for Telehealth. So we are out of the Office for Advancement for Telehealth. So all across the nation, we provide free services, presentations like I'm doing today, one-on-one consultations, that type of thing. And then as a consortium, we get together on a regular basis to try and make sure that we're all on the same page and giving out and answering questions in a similar manner. Next slide. We do have a national website. We do monthly webinars and kind of take different TRCs host each month, so you get a view of what's going on all around the nation as new and upcoming practices and stories from your peers. There's also a lot of reimbursement and marketing information and training tools on that website. This is just a snapshot of the Upper Midwest Telehealth Resource Center website. We have a lot of resources about reimbursement. I'll talk about some of those as we go through today. And we have all of our events where we go and provide live presentations at conferences in our region, also webinar events like we're doing today. Next slide. So I mentioned that we do a lot of presentations, training, one-on-one assistance. I really consider the TRCs like a Consumer Reports of Telemedicine or a Match.com because we are grant funded, so we have to be very objective in the advice that we provide. And we have to help people to find the right technology and the right information to provide their services. But we can't say, oh, this winter, is the best thing since sliced bread. We might say, oh, you want to do telepsychiatry. Okay, well, all you really need is a really good audiovisual video conferencing program. You want to make sure that it's compliant. Those types of things. So we might point you in the direction of 3 or 4 or 5 vendors that do that, and then you have to do your own due diligence to figure out what works best for your individual situation. Go ahead. So then getting back to telehealth and telemedicine, and what do you think of when you hear those terms? When I use the term telehealth, I'm talking about a broader field that includes wearable fitness devices, apps, all of those things could be part of a telehealth solution. But then a telemedicine program is that clinical billable piece of that solution. I also like to stress that telehealth in and of itself is not a service. It is a delivery mechanism. We're using technology to reduce or eliminate the distance between a provider and their patient. So within the field of telehealth, there are several different flavors or specialties, different areas of care. Telehealth was first invented really with the specialist, where a specialist was traveling between different hospitals and wanted to be able to stay put at one hospital but see patients from another hospital. So programs like telestroke or tele-ICU or telecardiology often fall in this area. And then we've seen over time integrated care where you might be physically at a primary care provider's office, but then seeing your psychologist or your psychiatrist. So that's more of a primary care medical home where they've integrated that the mental health provider into the primary care setting. And then I mentioned the code 99490 and that chronic care management. There have been other codes added since that initial code in 2015. We'll go over those. And this is a huge area because as we dig into the costs in our healthcare system, we find that those patients with chronic diseases represent a huge number or a huge percentage of the cost of healthcare in the United States. And then the last area is primary care in schools. And this is a very up and coming area. We have a program within the Indiana Rural Health Association where we're looking at this. There's several other really good programs around the nation. But looking at using telehealth solutions and digital stethoscopes and otoscopes and exam cams, what can a provider with prescriptive services see if the child is with the school nurse or whoever is taking care of that child when they come in complaining of whatever ailment, and then we have a provider on the other end that can prescribe. We can see that child while they're still at school. The parent doesn't have to take off work to take the child to a doctor. Maybe they can't get into their own doctor, or maybe they don't even have insurance and they don't have a primary care doctor. So we're starting to establish these programs so that these kids can be seen more efficiently. They're not missing school or they're not going to school sick. And also we're watching the data, early data returns, to see if we're also seeing a decrease in those communities in unnecessary ER visits. So more to come on that. That's a fairly new program. We've only been doing it about 6 months. So now we're going to switch over to federal policy and federal law. And we're going to talk about Medicare and Medicaid. So at the national level, we have Medicare services. And those services are the same throughout the nation. Go ahead, and then there's one more. Thank you. So Medicare pays for rural areas. There's not real regulations about it. It's based on CPT code, and the physical location of the patient must be in a rural area. Medicaid often mirrors a lot of the reimbursement of Medicare, but each state has their own Medicaid program and can tweak how they run their program as best meets the needs of their state. So every year, Medicare puts out this telehealth fact sheet. This year it happens to be 8 pages long, and it's got a list of who can provide services, what type of clinical environment the patient has to be in, the link to, and we'll see this again at the end of the slides, the link to the HRSA data warehouse, where you can go and look up the clinical location of the patient, see if it's reimbursable for Medicare for telehealth services. It's got the list of the CPT codes, all of this information. And it's the next couple of slides just give you an example of what those codes look like, and we're not going to spend any time on them. So go ahead and let's go through the next couple of slides fairly quickly. So here, Medicare, the telehealth reimbursement requirements, and I've kind of talked through this already, but this helps to give you a visual. The patient has to be outside of an MSA. They cannot be in a metropolitan statistical area. They have to be at a designated originating site, and they have to, the medical service being provided has to be within a certain CPT code range. And then the delivered service has to be delivered by an eligible practitioner. And that's what that fact sheet helps you figure out. Okay. So back in 2014, they revised the HPSAs and they created this data warehouse website. Now, I've heard that they're going to be revising the HPSAs again here this summer, but I haven't seen anything come out yet. And whatever they come out with this summer, then it won't become effective until January 1st of next year. But that's the website where you go to look up a clinical location where the patient's going to be and see if it's in a rural census tract where Medicare will pay for it. One of the 14 telehealth resource centers in the Telehealth Resource Center program is the Center for Connected Health Policy, and they're a national policy center. Every 6 months, they put out a new scan of the 50 states and the District of Columbia as far as Medicare reimbursement for telehealth, the different laws and reimbursement policies in specific states. This link here takes you to the last one they did, which was in April of this year. So in October of this year, they'll do it, release another one. And the reason I bring that up is it's very different when someone comes to me and says, hey, can I get reimbursed for whatever it is? I have to ask them a lot of questions to make sure we're talking about a specific situation, because the answer changes. There's 48 states that have a definition for telehealth and or telemedicine. New Jersey is in the process of getting a definition for telehealth, I believe it is. Rhode Island does not have a definition. So it changes depending on the state that you're in. And next slide. And then also, depending on the modality, some state Medicaid programs only reimburse for live video, kind of like what we're doing today. If we had our pictures up and we're talking back and forth across the Zoom platform. Other states reimburse also for store and forward, and that could be labs that are taken, an x-ray, a picture of a mole or a rash that is taken at one location, sent somewhere else to be read or reviewed or examined, and then sent back. And then remote patient monitoring, a lot of states are starting, Medicaid programs are starting to pay for remote patient monitoring, and a lot of that is keyed in with chronic care management and maybe a heart patient who comes out of the hospital and takes a Holter monitor or something home with them for the first 30, 60, 90 days. The other thing that really, it depends on when I answer questions about reimbursement for telehealth is if it's a private payer. So here in the state of Indiana, Anthem is one of our biggest payers. And there are 35 states, Indiana happens to be one, and actually all 4 of the states that I cover, Illinois, Indiana, Michigan, and Ohio, have some type of parity law. But these laws are crafted, and sometimes there's parity in coverage, meaning that if a private insurer or a commercial insurance program reimburses for something when the patient and the physician are in person with each other, then they must reimburse if they're providing the service via telehealth. So that's payment in coverage. Very, very few states have parity when it comes to payment. So if the charge for an in-person consult is $100, then the telehealth community says, well, it should be $100 regardless because the clinical care is the same if it's via telehealth or if it's in person. Some states have determined differently. The state of New York, for example, the law says that they only have, the commercial insurance providers only have to reimburse 75% of the in-person fee or reimbursement charge if the service is delivered via telemedicine. This data was as of April when the last scan came out. There were over 200 telehealth bills in 44 states that were introduced just in 2017. So a lot of it's about reimbursement. Professional standards. Here in Indiana, we added podiatrists as a type of specialty that could use or provide services via telehealth. So we're seeing a lot of incremental change in the different state laws all across the nation. Here's the new telehealth codes that came out this year. And these are the Medicare codes. So back to the federal level, these are the Medicare codes. So a lot of for end-stage renal disease. In 2016, we saw codes for end-stage renal disease for these different age groups of patients for a full month of service. And so now they added the codes for partial month of service. We've got new advanced care planning codes that can be used for the first 30 minutes and additional 30 minutes for discussion between a provider and a patient. And then we have this new telehealth consultation set of codes for the initial 60 minutes and subsequent 50 minutes when physicians are spending time up to 60 minutes communicating with a patient and other providers. Then there's the one other thing that's interesting that changed in the 2017 laws for Medicare is this place of service. Traditionally, we've used the modifier GT before the CPT code or the HCPCS code to identify that the service was provided via telehealth. In the summer of 2016, there was a code introduced or talked about, this POS02, and it's the location of service. And that 02 was to identify that the service took place at one location where the patient was when the provider was actually at a distance. And that the thought was that that would help Medicare to track more the utilization of telehealth. So this has not officially changed, but we do expect it to change in January 1st of 2018. And then the National Telehealth Policy Resource Center did put out a fact sheet on this whole idea of the new POS 02 code, and this is the link to that and some of the language from it. I said last year, the 2016 codes, I mentioned the end-stage renal disease codes. Also, we had some inpatient observation codes in 2016. Go ahead. Also in 2016, so 2015, the chronic care management codes came out, and it's interesting, the federal regulations that created FQHCs, federally qualified health centers, and RHCs, rural health clinics, is actually in Part A of Medicare. So a lot of times what we see is for the general population, a new change will come out, a new code will be added, and for whatever reason, it's only issued in Part B Medicare. So RHCs and FQHCs can't take advantage of it until it gets added to the Part A Medicare, which usually happens 1 year later. And I mentioned already that that 99490 code came out in January of 2015. So now we're pairing that with some additional chronic care management codes. They're not actually telehealth codes, but what they're doing is helping drive the utilization of telehealth to provide chronic care management services for patients when they're not physically at their provider's office. So here an additional 60 minutes of care or additional 30 minutes of care after the initial 20 minutes of care. And this graph just shows you a little bit more detail. There are certainly clinical standards that have to be met in order to bill for these codes. And the national average rates you see there on the bottom of the slide, $40.82 for the 99490, which is 20 minutes of care, versus $99487, $92 for 60 minutes of care, and then that additional $47 for each additional 30 minutes after that. You see there the authorized billing providers that can provide these clinical care services. Also, more information, the eligible patients for chronic care management have to have 2 conditions or more. And here's a list of all of the different chronic care conditions that fall under this particular program. And again, there's some requirements about the care being patient-centered, and that care plan that is established needs to be shared with outside entities, other caregivers in that patient's medical home. So I've said this before, so these codes are not telehealth codes, but they are being used to help promote a change from a fee-for-service environment in healthcare to a value-based service. Here again, the list of eligible practitioners for telehealth services. And then I just wanted to mention a little bit about next generation ACOs. There's a link there at the bottom if you wanted to join the next generation ACO program in 2018. But if you are one of those next generation ACOs, there is a telehealth expansion waiver. So the database that we talked about, where the patient had to be in a rural area and outside of an MSA, what this is doing is testing and allowing these ACOs to provide service to patients while the patient is at home. We hear so much about transportation issues in rural areas, and so many of those patients they're really trying to serve are elderly. They may not have transportation at all. They may not be able to drive. They may be homebound for various reasons. So this is going to be an interesting program to watch and see the outcomes, and to see if we have more insurance providers reimbursing when the patient's at home. Now, the other end of this, the other interesting piece of this, is that all of these virtual care platforms are popping up. Anthem happens to be my healthcare insurance provider, and they have a program called Live Health Online. So if I download this app on my computer or my tablet or my smartphone, and I utilize this app, it's free to me because I'm saving Anthem money and I'm getting services from one of their doctors. So I could be anywhere when I use that service. I could be at Starbucks or wherever I happen to be when I'm using that service. So it's going to be interesting to see how reimbursement evolves as technology really takes us forward to the next level. Something else that's been going on for the past couple of years is the Federal State Medical Board, or the FSMB, Interstate Medical Licensure Compact. This is specifically for physicians, and you can see here as of July 14th of this year, I think it's about 18 states have enacted this physician licensure compact. One of the rules about reimbursement for telehealth is that the physician has to be licensed in the state where the patient is at during the time of service. So there are more and more providers that want to provide services to patients in different states. Therefore, they have to go through this licensure process in each state. And this is just to help facilitate that program, that process, to make it easier for physicians to provide services over state lines. And, I've talked about technology throughout the slide deck today. So there's many vendors and many options. One of the telehealth resource centers is the National Technology Center. That's their website. They have a lot of different toolkits and user reviews so that you can look objectively at different services or different types of technology and make your own best decision. There's also some really cool devices, TytoCare, MedWand, Scanadu Scout, that are coming out for the consumer market. And what they're touting is more of a do-it-together technology, where they have guides that show a lay person where to put a stethoscope on your chest to get the best sounds for auscultation. So the ultimate goal here is all about increasing access to care. And how can we use technology to do that? So coming back down to the state of Indiana from a more national perspective, let's talk specifically about what's going on in the state of Indiana. So Indiana does have a law or a definition both for telehealth and for telemedicine. You'll see the consistency in that it's using telecommunications. It cannot be a telephone call. It can't be consultation, any other method of communication from the consultant to one provider or another. So here, the Indiana regulation for telemedicine, there's a specific method of delivery. Medical exams, consultations can be reimbursed, but focusing on using video conferencing equipment to render that exam. We often get asked questions about what if a patient is dual eligible, and that means they are both Medicare and Medicaid eligible. So in that instance, you would bill Medicare first based on the telehealth fact sheet. And then if it's denied, it automatically goes to Medicaid. And Medicaid will have a different code. So then you bill Medicaid. And if they deny the service on the fact that Medicare was not billed first, then you resubmit the claim to Medicaid. So effective July 1st of this year, we had some interesting changes, hopefully some very good changes here in Indiana as far as our Medicaid program. So back in 2014, Indiana Medicaid exempted FQHCs, RHCs, CAHs, or critical access hospitals, and CMHCs, community mental health centers, from a 20-mile distance limitation. So what that law said, or that regulation said, is that the patient and the provider had to be 20 miles apart before Medicaid would reimburse for a telemedicine visit. So now there is no more distance limitation in the state of Indiana. The only other state in the nation that I'm aware of that has distance limitation is Ohio. When we were in the middle of getting rid of ours in 2014, they instituted Medicaid payment in Ohio for the very first time. They put in a 5-mile rule. So also this law adds podiatrists to the definition of prescriber for telemedicine services. And it also talks about the services that are prescribed and contact the patient's primary care provider. So what this is trying to do is promote continuity of care. So if a patient starts seeing a different provider via telehealth, they want that primary care provider in their medical home to be aware of the services that are being provided. So the other big thing that this law did this year is it removed a limitation that was placed last year on July 1st for prescribing of controlled substances. Last year, officially, the Indiana Medicaid started paying for and allowing prescriptions via telehealth, but they said no controlled substances. And what happened, the unintended consequence of this is kids that were on things like Ritalin or other behavioral medication that was a controlled substance but not an opiate were then under constraint where they had to travel to their psychologist or their psychiatrist to get their prescriptions. They couldn't refill them via a telemedicine visit. So they changed the law to make it tighter to allow for controlled substances, but not opiates under specific circumstances, and also requires the prescriber to comply with INSPECT, which is the drug program in the state of Indiana where you can track and see what prescriptions a patient has been issued. There's other, there's other clinical things that must happen. I just wanted to give you an overview here. The other bill that I want to talk about today is House Enrolled Act 1540. This is all about pharmacies and pharmacists. So they made a huge number of changes. Usually a bill is like, I don't know, 6 to 10 pages. This pharmacy bill is like 26 pages. So they made a huge number of changes in the makeup of the pharmacy board in Indiana and who could be on the board, all of these types of things. There were a couple interesting things I want to point out about this particular bill. It allows the state health commissioner or a designated public health authority who is a licensed prescriber to issue a statewide standing order. So this might be used in case of Zika or some other type of influenza, those types of things, to issue a standing order that allows prescribers to go ahead and prescribe that. The other thing was it added immunizations to the list that a pharmacist can administer. So some of your very common vaccinations, measles, mumps, rubella, hepatitis, those types of things. And then it talks about public health emergencies here in this last bullet and administering immunizations under the standing order. A couple other things in this particular bill. It created remote dispensing facilities, which basically allows for telepharmacy in the state of Indiana. So the idea is that a rural pharmacy, a pharmacist makes a minimum of $100,000 a year, and a rural pharmacy may not have the volume to remain a soluble business, having to employ a pharmacist and a pharm tech and what other staff that they might need. But if you can have a way to use technology to share that pharmacist and therefore their salary over multiple locations, then that makes that a much more viable business in a rural area. So this is very, very exciting, and we're going to be keeping an eye on this and how this goes in the state of Indiana. The telepharmacy, the movement actually started about 10 years ago in the state of Iowa with a group of full independent pharmacies that were owned by a single family. And they didn't have enough business and had to close their doors, but then came up with this idea and were able to reopen those services. So there's also some stuff in this pharmacy bill about controlled substances and how pharmacies are involved with that, different things that happen if there is a felony, different charges, and pharmacists can act in official capacity, and it's a level 1 felony if someone causes bodily injury. So just to look back, I mentioned the bill last year about prescribing of controlled substances. The other thing that the bill last year did was, and this is House Bill or Enrolled Act 1263, it did allow for the establishment of that provider-patient relationship, or that physician-patient relationship, to be established on a first telemedicine visit. And that was the key to allow for a prescription during that first telemedicine visit. Also in 2015, and 1 year earlier, we had already seen coverage parity for Indiana, and I've talked about that. What Indiana has is parity in coverage, not parity in payment. And then prior to that, in 2014, they had established a telehealth pilot in Indiana, and that was really looking at the virtual care platforms, and were the outcomes for those patients, was the clinical care as good as in-person care. I've already mentioned some differences in FQHCs and RHCs, how the laws are different. And through our school program, we've done a lot of digging into this. And sometimes when you talk to people about telemedicine billing for an FQHC or an RHC, what they'll do is they'll go back to the federal regulations, which say that a FQHC or an RHC can only be what's called the spoke site, or the originating site where the patient is. But in Indiana, our Medicaid program pays for FQHCs and RHCs to be involved in a telehealth solution, either as the hub where the provider is at, or as the spoke where the patient is at. And this is, basically just what I already said. We do have a white paper on this on our website, since we do get a lot of questions about this. And there's my contact information. So it looks like we have a few minutes left for questions, and I'll take those now.